Hello and welcome to The Art of Aging, a part of our podcast series from the Center for Abundant Aging in United Church Homes. I thoroughly enjoy having conversations with others as we look at what it means to age in the 21st century, encouraging positive and empowering conversations that challenge, encourage, and inspire all to age with abundance. Today, I have the joy of welcoming Susan Wallace, President and CEO of LeadingAge Ohio. Welcome, Susan.
Thanks, Beth. Thanks so much.
Susan has her MSW and is currently the president and CEO of LeadingAge Ohio, which advances mission-driven, values-based care in the state. She began her career as a hospice social worker and quickly pivoted into policy and advocacy, leading state and national initiatives focused on improving the care for older adults and those in the final stages of life. She is a vociferous champion for caregivers, both paid and unpaid, and an active culture builder and servant leader. She holds her Bachelor of Arts and Master of Social Work from The Ohio State University. So first of all, Susan, why don't you briefly share what LeadingAge Ohio is and what is the connection to the national LeadingAge organization?
Yeah, happy to do so. And thank you so much for having me here, Beth. I listen to the podcast often, and it's fun to be asked. So LeadingAge Ohio is a membership organization. So our members are aging services and end-of-life providers. So there are about 400 members that we serve across the state of Ohio. And those include affordable senior housing, life plan communities, nursing homes, assisted living, home health, hospice, adult day. The thing that unites our members is that they are mission-driven and values-based organizations. Usually that means that they're not-for-profit. They're overwhelmingly not-for-profit organizations, but not always. We do have a certain number of proprietary organizations that we also serve at LeadingAge Ohio. And then we have a partner organization and great friends in LeadingAge National. So it's our Washington, D.C. based office. They help to try to corral the states, but also are at the front lines of the advocacy at the Capitol and in D.C. So they're wonderful assets to our membership. And to the extent possible, we try to be hand in hand with them. So for example, one of them is joining a webinar on Monday with us. So they're great folks.
Great. So you started your career as a social worker in end-of-life hospice care. Mm-hmm. Can you share how that experience has shaped your perspective in working with older adults that you do today?
Yeah, absolutely. So I guess I'll start a little bit early, which is why, earlier than that, with why I decided to be a hospice social worker. So I'm somebody that grew up with older parents. And as such, my grandparents, when I was very young, were the older old. So I had two grandmothers that were in their 70s, 80s, 90s when I was a young person. And I had a very close relationship with them. Both of them lived in town, and my parents were the primary caregivers in that regard. And then fast forward to my senior year of high school, my mom was diagnosed with metastatic breast cancer at the time. And she lived and worked and had a really great few years, but she did pass away when I was 22. And she's actually one of the short stay hospice patients. She was a younger person. She was only 55 when she passed away. And so she had only 7 days that she received hospice care. But during that 7 days, and actually shout out to Hospice of Dayton, they cared for my mom. And during that 7 days, I kind of saw hospice, and I realized, because I had received support from a cancer support center. When my mom was sick, I went to support groups. And that wasn't available everywhere. And I thought, oh my gosh, if everybody could be so prepared for this experience as I was as a very young person, that would be wonderful. And I realized that hospice was the care model that was available everywhere, that allowed people to be that prepared for the end of life. And so that was my mission. That experience with my mom was transformative for me. I grew so much, and I was the person in my family that knew what was going on, to the point that my dad sent us to have the first meeting with the hospice care team, my brothers and I, when we were just young adults. And I thought, gosh, if everyone can grow through this kind of experience, it's not something that anyone would ask for, but if you can experience that kind of personal growth, what a gift that is to give to others. And it's, a universal experience. We can all have that experience. And we can all grow through it, even in the hardest times. So,
Thank you. Thank you for sharing that story. I've known part of that story before, and you know what a great example that you set for others about how to take your life experience and how that really has directed your professional your vocation. I would use to say, and oftentimes people will talk about parents or grandparents who were older when they were younger influencing, but to have the added experience that you had with your mom and your dad and your family through her treatment and her death is really profound. So that was what decades ago,
yeah,
right? And so hospice has changed some since then, as has the public's perception of what hospice is. um, how would you define um, a hospice and end of life care, and what should people expect today in 2025 um, about hospice? Because I'm assuming that you would still say to others, hospice is really important and really helpful for not only the individual who is facing the end of their life, but the entire family system.
yeah. Yeah, absolutely. So I will say that a lot of hospice, most of what makes hospice special has not changed over that time, right? So I have a little bit of a love affair with the Medicare hospice benefit. I early in my career, sort of after I came out of that personal experience and into my professional experience, I quickly realized that hospice does things very differently than the rest of healthcare. And that, gosh, if we could figure out how do we take some of these critical elements and put it in other aspects of healthcare, we would all be, we would be better. And that continues to be a belief of mine, and it's something that fuels that. So some of those characteristics are things like having an interdisciplinary focus, a team-based focus. So in hospice, rather than having kind of a hierarchy, as you imagine, like a hospital or other ways that we do healthcare, it's a very flattened hierarchy. So there's you're looking at the individual's medical needs. So your nurse and your physician are very important, but so are your social workers and chaplains. And so it's one area of healthcare where chaplains are kind of supported and sort of equal parts in that team. And that was something that was very special to me. The fact that we make 24/7 access, that's something that's so important. Healthcare doesn't happen 9 to 5. And especially when there's a critical illness or need, that's something that needs to be available when it's available. And the other thing I loved about hospice is there's a lot of control that the hospice team has about what those treatment choices are. So if you think about the rest of the healthcare, oftentimes the control might be your health insurer making those
Right.
decisions. But with a hospice, the way it's structured is that there's a per diem amount, and the hospice is able to manage the care within that. And so those decisions, those clinical decisions, are very close to the family, and that just makes the care much smoother and easier for families. It relieves a lot of that burden about and a lot of that perhaps alienation that you get from working with big systems. So
Yeah.
so that has not changed. But I will say what has changed is the variation in hospice to hospices. So it used to be, when I started my career, most of the hospices that were providing care had been doing so since the late 70s. They were kind of grassroots organizations, and hospice has grown and become kind of a big business now. Most people have access to hospice care, which is wonderful. But there's a lot of variation from one program to another now.
I was talking with someone just in the past week, and she was going to mention hospice to a group of people, and one of the things that she was going to highlight was the fact that for a year, hospice provides grief care for the surviving members of the family. And I know from conversation with you, I said, well, no, that's not a mandate for all hospices, and that you had we just had this conversation, shared that there are some hospices who just like send a letter and that qualifies for their grief care. And it's interesting that this individual, she works almost exclusively with Hospice of Dayton. So a shout out to Ohio's Hospice. But she was really surprised. She's like, really? I said, yeah, there are differences.
Yeah, and
So
we'll talk more about those differences, but you're right. Every hospice is required to provide some kind of follow-up in bereavement for 13 months after. So they passed that 1-year death anniversary. That was really important in the design of the hospice benefit. But what that grief support looks like is very different. Some programs will employ counselors, and some will just, check in and refer to other local resources, but are not necessarily providing that service directly. There's a lot of flexibility in that, and that tends to be some of the difference from program to program.
So what are some of the other key differences between for-profit and non-for-profit care?
So before I jump into it, I will just say that tax status does not equal quality.
Right.
And when I said there's a lot of variation from hospice to hospice, that's just one factor. So that's important to note. And so I think there's other things that you can look at.
And the tax status is one of the differentiators between for-profit and non-for-profit.
Exactly. Yeah. So I will say most of the nonprofits that serve in hospice care have very long histories. So many of them were those programs that were founded in the late 70s, early 80s, sort of volunteer programs, grassroots. They've been doing it for a long period of time. Over that time, oftentimes you'll see more specialty programs that are available from not-for-profit programs. So not-for-profit providers are more likely to offer a community-based palliative care program, for example. If you look at the map across the state of Ohio and who's doing pediatric palliative care, which is, a bit of a heartbreaking thing to think about. But oftentimes those are the not-for-profits, not entirely. We have a couple of our members that are proprietary organizations that do serve pediatrics. Or if you have a local tragedy and you're looking for that community-based bereavement or grief support. So if there's something that happens, whether it's a shooting or a suicide or an event that has that community, oftentimes it is those not-for-profit hospices that come in, not entirely, but if you're looking across the board. So, and then sometimes specialty services. So things like dialysis or blood transfusions that can have a significant impact on the quality of life of an individual. Sometimes those are not always provided across the board, and it's more likely you're going to find some of those specialty services in not-for-profit operators. But again, the biggest thing is that, the sort of the governance structure, that not-for-profit is accountable to a board of directors. That board of directors is made up of individuals from within the community. And so that's sort of more of a sort of the way that the organization is designed. So hopefully that answers, but it's more complicated than tax status.
Yeah. Well, I can say during the 25 years that I was serving as a pastor in local church, the for-profit hospices were just really beginning to enter the market. Mm-hmm. And I could tell a difference when I would walk into a home and be with a family as to, is this a nonprofit or is this a for-profit hospice that's here? There's just... There's a quality piece. There's a depth of caring piece. So what should people look for?
So you touched on one of the pieces, and I think that's something that's really meaningful. So small versus large provider. A larger provider is going to have potentially more scale to offer more services. And you're right. A lot of the for-profit have been doing service maybe for the last 10, 20 plus years. So that's certainly enough. But if they're a new provider that's, been in it for a couple of years, might be just something to take a look, a little bit deeper look into what they're doing. Other things, there's some really great resources that are out there in terms of questions to ask. So I think what's most important is that folks know what is common across all hospices. You should have a nurse case manager that's helping to direct your care. You'll be seeing her at least every other week, if not more frequently. You will have a social worker that should be assigned and a physician, and then some other spiritual care or other type of counselor. So that's going to be every hospice program that you're part of. And so understanding how they manage those individuals. But then there's other services. So hospices, nurse aides are an important part of the interdisciplinary care team. So asking about, and then I would say other services like music therapy, art therapy, if there are pieces that are particularly important to you. Certainly, if you're somebody that's looking for some of those specialty services, that's really important to know if that's
Yeah.
something that's going to be important to you and if that's something they can provide. And then I would just say that a significant number of individuals that are enrolled in hospice today are residing in nursing facilities or assisted living. And so it's really important that you understand how those two teams work together and have a really good grasp of how well they work with the team that, you know, maybe is where your loved one resides or where you reside when you're thinking about that. So we do recommend that that families would ask their care teams at an assisted living or nursing facility what hospices they work with, and ask them, you know, why do they find that hospice helpful to work with. If it's just that they're providing staffing and making their job easier, that's one thing. Maybe that's a little bit of a red flag. But if they are there and because they have particularly skilled nurses, or they do a great job of being present with care conferences and making sure that they're informed, that's going to be tell you a different story. So those are the first ones off the top of my head. Would say there's a lot of resources too, though. Medicare has checklists, and there are kind of how do you shop for a hospice
Yeah.
tools that are out there.
Is there also kind of a quality measure that that hospice organizations are rated on that you can find?
There are. So Medicare has Hospice Compare. So it's part of the Care Compare website that you can go take a look. And I guess I should back up and say the first thing to know is that you have a choice of hospice program.
Mhm. Yeah.
I will say we get lots of questions as an organization about individuals that are choosing their nursing facility. You know, can you tell me which ones are good, or which ones, you know, what should I look for? I rarely get the question about hospice, and I think there's still this understanding that all
Mm.
hospices are the same. So I think that's real. The first really important thing is just know that you can do some shopping and learn. But there is a Care Compare website and Medicare. Worth noting that it's not required, unlike nursing homes. Not every hospice has ratings there. And so for me, I would want to look for a hospice program that had good ratings. If they're not on there, it means that either they're not reporting on quality data, or they're so small that their numbers aren't enough to be reported on the website. So that's
Interesting.
something that's important.
Yeah. I Something else I would add to the list, and this is again my perspective of having served in local church. There were some hospices that were very um, welcoming and to me as participating with the family in this process. I didn't attend their conferences, but they knew from the families that I was the local church pastor and that they trusted me, and I was in and out. And there were other hospices who were insistent that their chaplain be the one that tend to the individual. And as a local church pastor who already had a relationship with this individual, I was more than willing to accompany the individual and the family in this end of life process. And I know that there are a lot of my colleagues who aren't comfortable with that and are just as soon leave that to the hospice chaplain. But um, that was also part of my intuition as to which hospices worked and well and which ones didn't. And had to do with how they allowed other folks in the community participate in the support of those individuals.
Yeah, that's a great point. Another really critical role for people is oftentimes their physicians. So how well would that hospice allow you to continue on with your own physician relationship and manage that? And that's a complexity, that requires the hospice to
Yeah.
be, planning and coordinating in a sort of a heightened way. And I think that's a great piece to point out.
And we know also that there are hospice organizations that we see in the news situations of fraud for
Mhm.
billing for ineligible patients or um, scams targeting facilities. What are the trends that you're seeing, and how can families protect themselves from being caught up into those less than legal and ethical situations?
Yeah, this is really unfortunate. And so hospice has been one of the target areas and sort of the focus areas for fraud in healthcare fraud across the country. I will say, thankfully, here in Ohio, we have not seen instances that are so egregious as some of the situations that we've heard, particularly in the Southwest states. So, starting in California, but then as California has cracked down and become very stringent, we're seeing more fraud activity in Arizona, New Mexico, and Texas. But those things are things like enrolling individuals that don't know they're on hospice. They're telling them they're palliative care and not letting them know. Enrolling individuals without any knowledge, so outright frauds, taking Medicare numbers and enrolling them. There have been instances of no services rendered, so enroll, but there's no actual hospice services being provided, or essentially setting up shell hospices. So we had instances of hundreds of hospice provider numbers being had the same address, and there's nothing inherently illegal about that, but my gosh, what's going on there, right?
Yeah.
So luckily we haven't seen that here in Ohio, but it is something that's sort of that's been going on, and it's something that we are paying attention to, and just to keep an eye on things. What we have seen is significant growth in hospices over the last couple of years. So we've seen since 2021, I think we've seen almost 50 new hospice licensure applications, and that's a dramatic increase. And so that's something we're kind of paying attention to, and having a dialogue with the Department of Health to understand what's going on there. But at this point in time, not necessarily seeing fraud.
So I think one of the things that people may not be aware of, and that this may also be a part of setting up the possibility of fraud, is that Medicare pays for hospice, right?
Mm-hmm.
And Medicare does not pay for long-term care. So that's a point of distinction that I think it is helpful. And I know that there are times when individuals and families get to the point where their loved one is, the doctors say, have you considered hospice care? And they don't want to consider it. And not that we should do it for the money, but end-of-life care can be very expensive. And, I wonder if they know that this can help alleviate some of the financial burden for the family to enter into hospice care.
Yeah, I think it is important to know that, Medicare is entirely paid, hospice is entirely paid for by anyone that has a Medicare benefit. I think there's one exception with respite care. There's a small copay per day. But it does mean it's paid at a per diem as well. So there's, when you compare it to other care settings, there's certainly a vulnerability to fraudulent activity.
Right.
So,
right.
yeah.
So what is the difference between palliative care and hospice care? They're related, but I think that there's a lot of confusion in the general public about the relationship and the difference.
Yeah. Well, so I'll start off by sharing that all hospice care is palliative in nature, but not all palliative care is hospice. So hospice is a very specific kind of palliative care that is just for end of life. So palliative really refers to the approach to care for individuals that have complex illness at any stage of life. So palliative care would be appropriate for an individual that was perhaps newly diagnosed with cancer, that were newly diagnosed with a chronic disease that's going to change the trajectory and what their life looks like on a day-to-day basis. Palliative care it is typically something that is looking at coordination of care, very preference sensitive. So looking at an individual person's values and how those translate into care decisions. Looking at symptom management very aggressively in a person-centered way. And so those are all skills that any palliative care operator may have. Hospice care is taking that approach and putting it into a Medicare benefit that has prescribed services. So hospice is very well defined as a Medicare benefit. Palliative care does not have a Medicare benefit or necessarily any national standard on what that has to look like from one program to another. So it's more of a philosophy approach.
Interesting.
So that's probably the biggest thing is Medicare defines, and so there's a more standardization in the hospice space even than there is in palliative care.
One of the challenges that I see, particularly for the families and the caregivers, is our entire lives, we are told if somebody is in physical distress and you can't take care of it, you call 911.
Mhm.
And when somebody goes into hospice care, and palliative care is the philosophy of care underneath that, um, you don't call 911. Or if you do, you have to let the folks who come know that this is a hospice patient. Explain why that's important, and it's so challenging because we've been trained that's what you do, but we get to this point, we want to care for our loved one, they're having a hard time, and we have to stop that being our initial
Yeah.
impulse.
Yeah. Well, it's important to distinguish, well, what isn't palliative care? So when we talk about palliative care, the other flip side of that is curative care, right? And almost
Right.
all medical care is curative. In almost every other situation that you're interfacing, there's a problem and you need to fix the problem, right? And
Right.
so your emergency medical folks, your ERs, hospitals, typically 90+% of what they're going to do is focusing on fixing a problem. But when we're talking about palliative, that's more complicated, right? So it's even if you're not on hospice and you're not at that end of life, typically it's a chronic illness that you're grappling with. It's not something that's going to be fixed, and so there's more complexity there. And every curative treatment has consequences. And so a lot of what palliative care operators are doing, clinicians are doing, is helping folks walk through those, the trade-off that you have between, okay, do I want aggressive treatment here, or in what's the consequence of that, and am I okay with that consequence? So am I okay if I have this very aggressive chemotherapy, and that means that I, might be laid up for my loved one's graduation, right?
Right.
Or maybe how do I time that to make sure that I'm maximizing my quality of life? And so that's what's really important, and especially as we get towards end of life, those aggressive treatments are perhaps less successful and have an even more detrimental impact on our quality of life. And so, really, quality of life is the guidepost, not fixing something for palliative care.
Yeah. So there's another program option out there that I know that LeadingAge Ohio and that you are involved with, and that has to do with the program for all-inclusive care of the elderly, PACE programs. That's also a palliative care based philosophy, right?
Yeah, it is. Although sometimes it's provocative when I say that, because I think that folks don't always, if you're thinking about, okay, I have a palliative care program that does, community-based care, and we're out in communities. PACE is is another kind of palliative care, in that it has the same focus. It is interdisciplinary in nature, and it's focused on quality of life, and it is for individuals with complex chronic illness. So kind of ticks all the important boxes for palliative care, but it's also a defined care model. And it's one that's it's not unlike hospice, where it's prescribed by Medicare and Medicaid. In this situation, it's both. So the thing that makes PACE very different is it's not just a care model, but it's actually also an insurance product. So that's something that folks have to wrap their heads around. So PACE, when you enter into PACE, not only are you saying this is my provider that I'm going to choose, but this provider is going to manage all of my Medicare and Medicaid benefits for essentially a monthly fee. What that means is that I mentioned sort of how much the hospice benefit simplifies somebody kind of coming on to that. It also, that it has that same impact, right? So rather than having to check and make sure a service is pre-authorized, you're working with your care team, and your care team has the authority to make that decision because the provider and the payer are the same. Now, I will say everybody might want this if it existed for everybody, but it's most impactful for individuals with particularly chronic, particularly complex illness. So in order to qualify for PACE, you have to have sort of a nursing facility level of care. So it's somebody that would otherwise need the support of a, skilled nursing in order to get through their ADLs. And they also have to be residing in the community, at least when they're enrolled. So that usually means they might need a caregiver or some sort of informal support to be able to reside in the community safely. So, but some folks with PACE might need nursing facility care at some point in time. And so that PACE provider is then going to be working with the nursing facility or the hospital if there's that situation, because they're the payer. So they're going to continue to follow that individual throughout.
Now, I know that in Ohio, we have entered into PACE very cautiously and very slowly. So it's not available to everyone in the state of Ohio at this point, is it?
Mhm. It's not, and I will say that in most states where PACE is available, it's not available everywhere. So it's very much sort of it's a three-way agreement between the state and the PACE organization as well as the federal government. So it's sort of they come together, and because they're so thoughtful about expansion, they typically will define a geographic area. So in Ohio, we're looking at counties. So in Ohio, we have gone from only having PACE in one county for most of the last couple of decades. It was only available to individuals in Cuyahoga County up in Cleveland, to it being available by about this time next year, we'll have it available in 10 counties. So 10 out of 88 doesn't sound like a lot, but it will be covering, there will be PACE available to more than half of the older adults that reside in the state of Ohio, just because it's those metro counties that are going to be. So this is a really big change, and we are incredibly pleased that Ohio has been kind of coming along. We've had a wonderful partner in the Department of Aging, as well as the Department of Medicaid, who are all coordinating to make this happen.
And I think the biggest challenge is going to be educating people to know what it is that this is, and to help them to decide if this is an option for them, just because it hasn't been around Ohio and most people have no idea.
Yeah, absolutely. It's very niche. So not only is it, is there sort of the, okay, what is palliative care and what does it look like to make your care decisions based on, quality of life, but also it's, okay, it's not a provider, it's an insurance product. So what does that mean? So it's something that's perhaps not in our normal, the way that we think about healthcare. But I think it's just so incredibly exciting. PACE has incredibly high approval ratings from participants, like 95 plus in terms of their satisfaction with being in the PACE program. And usually folks come into PACE and they immediately feel like a relaxation and like kind of a, oh, okay, I don't have to manage everything now. I have a whole partner team that will help me manage through that. So it's an incredible care model, and we can't be more excited.
So, affordable housing, long-term care, hospice, PACE, LeadingAge Ohio covers a lot of different options, most of which are centered and focused on those who are aging later in life. What are some of the things that you think are most impactful in helping people to age differently or to experience quality life by these services that are part of LeadingAge Ohio?
So, gosh, you mentioned all the services that our members provided, but I'm going to actually answer something that our members don't provide, which is, I would say, caregiving and social connection is probably, if I was thinking about one factor that helps individuals move forward in aging in a healthy way, regardless of what their care setting or medical status is, to the extent to which they can be in relationship with individuals that are helpful to them. That could be dear friends, that can be family. I think that's probably the most important thing. And so, all of the work that my members do is only this much of aging, and so much of aging is with informal support from families and loved ones. So if I were thinking about what positions somebody well to age, it's relationships and it's people, which is not terribly surprising, right? So
No, but it's true, and the reality is, it doesn't make sense, and it's just not realistic for us to think about building enough long-term care communities or life plan communities or PACE programs that would take care of everyone. And at United Church Homes, as we are entering more and doing what we call middle market, the reality is there are way more options than people know. And then so I think that education piece and helping people understand what the options are where they live, and how they can discover what's going to be best for them and their family is one of the biggest challenges that we have going forward.
Yeah, and I would just say, even just thinking like very logically with demographic shifts, we can't care. There's no way we
Exactly.
can care for
Exactly.
everybody with the formal support system. And so, to the extent to which we can do models that sort of have a lighter touch, and PACE is one of those. I
Yep.
would say Naviguide is another
Yep.
program, the
Yep.
United Church Home Service Coordination program that has that kind of light touch to support caregivers.
Yep.
Adult Day is another one. Those are the ones that you really get the most bang for the investment, and they're just so incredibly important. So,
Yeah.
yeah.
Well, we have a lot of work to do. Definitely, you are not bored,
Never, never a dull day.
and leading age is not without opportunities to find new ways to live out its mission. So, as we bring our conversation to a close, and there are so many other things that we could talk about, Susan, and maybe we'll do that in another time, in another episode. But you know that we have 3 questions that we ask of all of our guests. So, are you ready?
I am. I'm so
Okay.
ready.
When you think about your own aging, what has changed about you? Um, and what do you like about your older self?
So, so I will say that I'm going to answer this question. I am firmly in middle age, and I own my age. I am 45. So, what I love about midlife is less preoccupations with just what the world thinks, and more comfort with who you are, getting to know yourself deeper, and good and bad. It's not always pretty what you learn about yourself, but I would say sort of that comfort in my own skin that has kind of come in midlife is probably my favorite part about growing older.
Yeah. And I think Chip Conley, he doesn't talk about middle age. He talks about middle lessons.
Middle lessons.
Middle lessons. Yeah.
But
Yeah.
is that like even sometimes I wonder, it's like, well, middle age is that just us trying to reframe it, and because we're afraid of that word age, right? I don't know.
We'll have another conversation about this.
I would love to.
Yeah, I heard some interesting observations about this. So I'm kind of wrapping my head around that
Yeah.
concept. Second question, what surprises you about what you're doing at your age right now?
So I think the thing that surprised me most, so when I was in my late 30s, I started painting. I started doing watercolor. I don't know where it came from. It might have been my kids in those little Crayola watercolor kits when they were littler. And I remember it was just such an aha for me, because I remember being a young person, and my big brother was an incredible visual artist. He was always drawing, and I played in band, and I did music. And I decided at a very young age what I was. And I think that's been what's really exciting, is realizing all these things that you decide that might not actually be true, and what capacities are out there that maybe we're not even taking into consideration. So I think that's probably what surprises me. And I'm always curious about what else might be in there and what else might be possible. So.
Yeah, we had a conversation recently with a music therapist, Liz, who you know, and she was talking about how many people she runs across as a music therapist who recall the 5th grade teacher who told somebody you can't carry a tune, and how we hang on to some of those messages from our childhood, carry them way into adulthood, and we need to let go of those. We need to get those negative voices out of our brains, and allow ourselves to continue to grow.
Yeah.
Okay,
Absolutely.
the last question. Is there someone that you've met, or someone who set an example that inspires you to age abundantly?
So I'm going to go back to the first question or one of the first questions you asked. My father's mother, so my grandmother, Millie, she was living on the family farm into her 80s. And that was not necessarily what was most impressive, although it was impressive that she was living, solo in this massive, farm. What was really impressive for me is when she decided, I'm done here. And she chose to move to an independent living community. She was one of the first residents of 10 Wilmington Place in Dayton, Ohio, which is still operating, a wonderful community. And that was the vision of aging that I had. So it was her being a card shark, taking home all the candy bars, and it was playing pool in the basement, and it was having all the family gatherings in that community in the private dining room. And it was all the relationships that she carried from the farm, and the letters she wrote. And that's what I think about. And it was all, even when she had to move to a skilled nursing community down the road, she was crocheting by feel. She had macular degeneration. Wow. And so I have blankets that she made when she was unable to see. And so I think that's for me. And she just found a way to find joy and meaning, regardless of what stage she was in. And she was always the decider, which I thought was just amazing. So if I get the luck to have all of my cognitive abilities like she did as I get older, that's my goal. And I tell people often I have this goal of 3 digits. I hear that we should be able to make it now. I don't know if I'm going to make it, but I would love to have a rich older life like I watched when I was a kid.
Oh, great. I also had a grandma Millie. So thank you for sharing. If anyone wants to be in touch with you, where can they find you or be in touch?
So probably the easiest place is our website. So leadingageohio.org. You'll see an about and a staff contact list, and you can get a hold of myself or anyone within our team easily through there. So that's probably the easiest way to find us.
Thank you. And this will not be our last conversation, and we'll decide in the future if we want to record any of our other conversations. It's always great to be with you.
Absolutely.
So thank you. And thank you to our listeners for your time with this episode of The Art of Aging and part of United Church Home's Abundant Aging podcast series. I invite you to visit our website, abundantaging.org, to explore further notices or topics around abundant aging. And you can find our other conversations on the art of aging wherever you listen to your podcasts. In the meantime, may you look around you and identify a person who is aging ahead of you, who influences your understanding of how you can age abundantly by their aging example. Until next time, thanks for listening.